My name's Rebecca Catafloris, and I'm a clinical nurse consultant and one of the Victorian viral hepatitis educators based at St Vincent's Hospital in Melbourne. We're funded by the Department of Health to provide education and training to the Victorian healthcare workforce on hepatitis B and hepatitis C. So today I'll be talking about Hep B and Hep C screening and management. Before we start, I'd like to acknowledge the Wurundjeri people of the Kulin Nation as the traditional custodians of the land on which I work. I'd like to pay my respects to elders past and present and extend that respect to any other Aboriginal and Torres Strait Islander people who are joining this webinar. I'm going to start by talking about hepatitis B virus. We know that hepatitis B is a global issue. It can lead to significant disease of the liver, advanced liver disease progressing to fibrosis, cirrhosis, and liver cancer, or what we know as hepatocellular carcinoma, or HCC. So the hepatitis B virus itself is the second most important known carcinogen after tobacco globally. We know that many people will generally feel well and healthy with hepatitis B virus, but we're moving quite away from the term healthy carrier. Everybody with hepatitis B will need monitoring, and a percentage of people will need treatment for hepatitis B. Chronic hepatitis B is considered infection that lasts longer than 6 months, and once hepatitis B is chronic, it is lifelong. Since 2000, we have in Australia the hepatitis B vaccine that can offer significant and effective prevention offered to all newborns in Australia, as well as other high and at-risk cohort groups. So hepatitis B is transmitted through infected blood or bodily fluids, and those fluids are semen and vaginal fluids. It must enter the bloodstream through either broken skin or mucous membranes. We know that globally, most people who are infected with hepatitis B are infected at the time of birth or early in life. In saying that, a number of children and adults can certainly acquire hepatitis B through other means other than perinatal transmission. And we know also that more than one person in a family is often infected. So perinatal transmission is by far the most common means of transmission of hepatitis B virus. We have an excellent screening program in Australia of pregnant women, but in saying that, many people from high prevalence countries who currently live in Australia may be unaware of their diagnosis of hepatitis B or indeed their child's diagnosis of hepatitis B. Other ways that Hep B is transmitted can be through the sharing of household items such as razors, toothbrushes, etc. Indeed through unprotected sex, and also horizontal transmissions, for example, transmission from child to child through broken skin or a wound. It's really important to offer testing and screening to a number of people. This list is not exhaustive, but it certainly highlights the most significant and high-risk client cohorts that we would want to be screening here in Australia. That includes people born in high prevalence countries and Aboriginal and Torres Strait Islander people. It includes partners and sexual contacts or household contacts of people with either acute or chronic Hep B, people who have ever injected drugs, people who have ever been in prison, men who have sex with men, people co-infected with HIV or hepatitis C, and as mentioned, pregnant women. But ultimately, anyone who requests a test should be offered a screen for hepatitis B, and certainly anyone who presents with symptoms of liver disease, including cirrhosis, should be tested, or follow-up should be offered to people who have previously tested positive but have received no follow-up since that time. This diagram shows the current cascade of care in Australia for people living with chronic hepatitis B infection, and these data have been taken from 2020 with courtesy to the Doherty Institute. So we know that there are approximately 222,500 people living with chronic Hep B in Australia, but only 73% of them have actually been diagnosed. So there are 27% of people in Australia that are still yet to determine their Hep B status. Of the diagnosed people, only 22.6% are currently engaged in care, which leaves just over 77% of people not engaged in any care at all. And the third National Hepatitis B strategy for 2018 to 2022 states that we need 80% of people with hepatitis B diagnosed. So of that 222,000 people, which is just under 1% of Australia's population, we're actually striving to diagnose a minimum of 80%. The strategy also outlines Australia's target for 50% to be engaged in care, and at present we're at 22.6%. And of those 22.6 engaged in care, we need to have 20% of people in total on treatment. Australia's target is 20%, but of those currently, we only have 10.7% receiving any treatment at all, and a further 9.3% of the 20% are not receiving any treatment. So our focus in general practice and primary care, including monitoring and treatment, is really targeting the missing and undiagnosed 27%. We want to also know where are the 77% not in healthcare. So opening up those conversations about testing, treatment, transmission, prevention, risk factors, having those conversations with our patients and offering screening at the first instance. So to test and screen for hepatitis B, we need to order a panel of 3 tests when we request pathology. These include the Hep B surface antigen, Hep B core antibody, and Hep B surface antibody. The surface antigen will tell us if the client currently has infection with hepatitis B virus. The core antibody will tell us whether they have had infection at some point in time. And the surface antibody tells us if they're currently immune or protected against hepatitis B. We need these 3 tests together to determine the full status of someone's hepatitis B, be it current infection, susceptibility, or immunity through either vaccination or past infection. One of those tests on their own is not sufficient. We need to have all 3 tests to determine the appropriate status of the person. All of the tests are Medicare rebatable, and when you request your pathology, on the form you need to write query chronic hepatitis B. All of those tests will then be ordered. Following that serology, if a person is hepatitis B positive, then a number of other tests, including liver function and a range of hepatitis B specific tests, can be ordered, and that can be done in conjunction with a specialist or nurse practitioner. But in the first instance, in primary practice, it's vital that we order the surface antigen, core antibody, and surface antibody. The ASHM website has the decision-making tool available online to support your interpretation of results, and Section 3 will give you a variety of test results, be it susceptibility or non-immune, immune due to resolved infection, immune due to Hep B vaccination, certainly acute or chronic hepatitis B infection, and other obscure possibilities, including distant resolved infection, recovering from acute Hep B, false positive, or occult Hep B. So this decision-making tool can also guide you through assessing the phases of infection, but certainly you don't need to do this alone, and a specialist or nurse practitioner can support that process with you. As I mentioned earlier, everyone with chronic hepatitis B needs 6 to 12 monthly monitoring. So this will usually include a liver function test And for some people, it will also include an ultrasound plus additional serology. As I said earlier as well, we no longer refer to someone being a healthy carrier. We know that hepatitis B virus is dynamic. Viral load can certainly change over time, and the disease progression can increase depending on other factors. So, regardless of whether someone is taking medication, everybody with chronic Hep B needs 6 to 12 monthly monitoring. And more GPs are now really effectively co-managing people with chronic Hep B who are well and stable. They may do this with the support of a specialist such as an infectious diseases specialist or gastroenterologist or nurse practitioner, but many are able to do it on their own. And a significant number of people won't require any treatment at all. Only about 20% of people will need antiviral medication, which is S100 meds, to reduce the viral load and therefore minimise the risk of further liver disease, the progression to fibrosis, cirrhosis, and the eventual risk of developing liver cancer. Tablets are taken daily, very well tolerated, very minimal side effects. Once they're commenced, they're generally lifelong. And a number of people will also require hepatocellular carcinoma surveillance or HCC surveillance, so screening for liver cancer. A 6-monthly ultrasound, plus or minus an alpha-fetoprotein serology, is recommended for patients with chronic Hep B, specifically Asian males over 40 years of age, African people over the age of 20, Aboriginal and Torres Strait Islander people greater than 50 years old, Asian females greater than 50, anybody at all with cirrhosis, and anyone with a family history of liver cancer. Now I'm going to talk about the hepatitis C virus. Hep C is a virus transmitted by blood-to-blood contact, so the blood from one infected person entering the bloodstream of an uninfected person. There are a number of people who are high risk for hepatitis C. We know that people who inject drugs or have a history of injecting drugs make up about 90% of new hepatitis C diagnosis. This doesn't just include the use of sharing needles, but it may include the use of injecting drug use equipment such as tourniquets, spoons, and filters or water. Other high-risk practices include things like backyard tattoos or body piercings, tattoos and body piercings done overseas in countries that don't have regulated or auditory bodies. We know that people who have ever been in prison are up to 28 times more likely to test positive to hepatitis C than the general population. And so they too are a high risk group and people that we definitely want to be testing for Hep C. Anyone born in a high prevalence region for hepatitis C, including parts of Africa, Asia, Eastern Europe, the Mediterranean, Egypt, Pakistan. Anyone who's been exposed to unsterile or medical and dental procedures in high prevalence countries. Anyone who's had a needle stick injury, partners of Hep C positive people, men who have sex with men or who are co-infected with HIV or Hep B. People who have been the recipient of a blood product or donor organ in Australia prior to the 1990s when our screening program commenced. Certainly anyone with liver disease that may be associated with viral hepatitis. And although mother-to-child transmission is low, we still want to be testing people who may be at risk. And certainly anyone who requests a test for hepatitis C, anyone who also has cirrhosis or liver disease, and again, who's tested positive in the past but had no recent follow-up. There are two screening tests. There are two tests for hepatitis C. One is the hepatitis C antibody, and that determines if a person has ever been exposed to hepatitis C at some point in time. The Hep C antibody test doesn't determine if the person has current or past infection. So once the person has been exposed, the antibody will remain positive forever. We then need to request a Hep C RNA, often interchangeably known as a PCR, in people who have a positive Hep C antibody test or who have ongoing risk factors to determine whether they actually have current infection. So the positive antibody and a positive RNA will indicate that the person has been exposed to Hep C and they are currently infected with Hep C. A positive antibody but negative RNA will tell us that there has been exposure at some point in time, but the person is not currently infected with Hep C, and that may be due to spontaneous clearance of the virus, which occurs in about 25% of people in the first 6 months of infection, or prior treatment, which we now call a cure. And a negative antibody and negative RNA or negative PCR will tell us that the person has never been exposed to Hep C and is not currently infected with Hep C. So in ordering pathology, we need to request reflexive HCV RNA as well as LFTs. So you will initially order the Hep C antibody test and specify that if the hepatitis C antibody test is positive, that the person then needs to be tested for Hep C RNA or PCR. So it's that qualitative test as well as LFTs. And the ASHM website has this decision-making tool for hepatitis C, talking you through whether the person doesn't have hepatitis C and what action to take, if any, whether they've cleared their hepatitis C virus and when to retest. For instance, if there are ongoing risk factors, the recommendation is to repeat that RNA test every 12 months. Or if they have chronic hepatitis C, which is deemed longer than 12 months of infection, how to do further assessment and treatment. Since 2016, hepatitis C treatment is incredibly easy to cure with direct-acting antivirals. These are new treatments that have a cure rate of approximately 95%. You may hear some of your patients or clients talking about interferon and ribavirin. These are the previous treatments that were available prior to 2016. They were difficult to tolerate, 6 to 12 months in duration, included tablets and injections, and had multiple side effects, multiple unwanted side effects. If your client or your patient isn't aware of the direct-acting antivirals, this is a great time to talk about them because they are easy, effective, they have very few side effects. Mild side effects do include headache, nausea, and fatigue, which is commonly what people with hepatitis C infection are experiencing already. And the majority of people will be cured after 8 to 12 weeks of daily tablets. GPs and nurse practitioners can prescribe Hep C medication for their clients if their client is not cirrhotic. If they're cirrhotic, you would refer to an infectious diseases specialist or gastroenterologist. And the role of the GP and your practice staff in both hepatitis C and hepatitis B screening and management is really offering anyone with risk factors a screening test, understanding that everybody with Hep C can receive treatment. They don't need to have stopped using drugs or alcohol or engaging in other risk factors. They can still be treated. Hep C treatment can be undertaken various times if required. Although it cures hepatitis C, it doesn't give the person immunity to Hep C, so they are still susceptible to acquiring the infection again if they cure their Hep C in the first instance. Hepatitis B treatment will be lifelong. GPs and nurse practitioners can prescribe Hep C treatments for people without cirrhosis. S100 prescribers in the general practice can manage and treat hepatitis B very well. You can refer to a specialist physician, gastroenterologist, or nurse consultant for further assessment and support, also assistance with contact tracing. Hepatitis B and C are both notifiable conditions in Victoria, so referring to the Department of Health. And remembering that clients with hepatitis B and C do often have various other health issues and will commonly need additional supports, things like immunisation, interpreters, visual resources, referrals to mental health services, housing support services, community health centres, etc.